Well, good morning, everyone. I'm Murli Doraiswamy. I'm a professor of psychiatry and geriatrics here. I will serve as the chair for the first session on biomarkers and health disparities in Alzheimer's disease. I want to thank the organizers for having me here and all of the distinguished speakers for coming down. Before I introduce the two speakers, I want to share a couple of slides. Have people seen or heard of Dr. Solomon Carter Fuller? Or is this the first time you all are seeing this? So Dr. Carter Fuller was actually the first African-American neuropsychiatrist and pathologist in the United States. He did not have sufficient opportunities in the US at that time. I think he was trying to get a tenured professorship at Boston University. He was sort of rebuffed. So he went to Germany, where he got a visiting scholarship in Dr. Alzheimer's lab. He was actually the first person to describe neurofibrillary tangles. His contribution has unfortunately not been fully recognized because 100 years ago, I think visiting scholars and African Americans were generally not attributed for the discoveries and inventions they had made. So I think it's time for us as a field to recognize his contributions, and hopefully we can sort of do something to remember his memory. So maybe a prize. Maybe the Alzheimer's Association. I'm looking forward to, hopefully, you all can do something. So we've heard many people talk about biomarkers. I think many of you are familiar that last year, several working groups, including the Alzheimer's Association, introduced these revised research criteria for the diagnosis and staging of Alzheimer's disease. And you can see the different biomarkers categories that they have come up with. A and T, amyloid and tau are still the core biomarkers. And then they have non-specific biomarkers, which is N for neuronal injury, I for inflammation, and then biomarkers of comorbid conditions, which is V and S. So we have now an expanded list of biomarkers, and blood biomarkers hold huge promise for changing every aspect of the patient journey, from prediction to accurate diagnosis, to personalized treatment selection, even monitoring side effects of treatment. But at the same time, we need to make sure as a field that they're fully validated before we implement them. We need to make sure we understand all of the biases. Otherwise, we will end up causing more harm than benefits. And that is where the next two speakers in this panel are going to share some new data about. So let me introduce the first speaker. Dr. Michelle Mielke is Professor and Chair of Epidemiology and Prevention, as well as Professor in Gerontology and Geriatric Medicine at Wake Forest University and the Stick Center for Healthy Aging and Alzheimer's Prevention. Dr. Mielke works as a translational epidemiologist and has done pioneering work to identify fluid and neuroimaging biomarkers for the diagnosis, prediction, and/or progression of neurodegenerative diseases. She serves on the FDA's Peripheral and Central Nervous System Drugs Advisory Committee, so you're in the hot seat over the next few months. She has more than 300 peer-reviewed publications and is a PI on several NIH and foundation-funded clinical and epidemiological grants.
Thank you so much for that introduction, and it's really an honor to be here. The program looks fantastic, and so I'm really looking forward to learning from all of you. Do I have to talk into the mic for people online?
No.
Does that? Okay. Great. So today I'm going to talk on a number of levels to get you thinking as what was just discussed about implementation of blood-based Alzheimer's biomarkers at the population level. All right, great. Thank you. So these are my disclosures. I'm right in the middle of everything, aren't I? Okay. So as was mentioned, the technological advances really in the past 5 and 6 years have been an incredible accomplishment, and have led to the development of assays to utilize blood-based biomarkers for the diagnosis of Alzheimer's disease. And certainly from a population standpoint, there are a lot of limitations of amyloid PET, for example, or lumbar puncture for CSF at the population level. They're costly, they're invasive, and not as accessible or feasible in more rural populations. Multiple studies have shown the potential clinical utility of plasma measures of both amyloid beta 40 and 42, as well as phosphorylated tau. And some of these assays are available clinically, not FDA approved yet, but they are available clinically. And some of the immunoassays on platforms such as the Roche Alexis, LumaPulse, and other platforms can be reimbursable using standard immunoassay CPT codes and are being used clinically right now. However, most studies that have been done today in the research sphere have been focused on non-diverse individuals. These are generally clinically very well characterized individuals. They tend to be white, younger, and of higher SES populations. And so as these blood markers are becoming clinically available and are going to be used at the population level, there's really a need to understand how they perform in the population, more specifically in more heterogeneous, diverse populations, as well as what factors might affect their interpretation. Now, as I mentioned, a lot of the work to date has been done on younger individuals, more pure individuals with Alzheimer's disease in terms of understanding the clinical utility of the biomarkers. But that's not the typical person that's diagnosed with dementia at the population level. And so if we think about the average age of a person with dementia in the US, it's about 84 years old. And 60% of adults with a diagnosis of Alzheimer's disease have 3 or more chronic conditions. The prevalence of these chronic conditions are even higher among African Americans and other underrepresented minorities, as well as individuals of lower socioeconomic status. Now, we know that chronic conditions and frailty are risk factors for Alzheimer's disease, and they can affect the expression of AD pathology with regards to cognitive function, disease stage, and also neuropathological burden. Now, polypharmacy often co-occurs with the multiple chronic conditions, making it even more difficult to try and understand what is going on for a patient who's presenting with cognitive impairment in primary care. And as a result, it really makes it difficult to diagnose dementia and dementia type. And in fact, it's been estimated that about 50 to 70% of symptomatic patients with ADRD are not recognized or incorrectly diagnosed in primary care. Unfortunately, there's also a very limited capacity of Alzheimer's disease specialists, whether geriatricians, neurologists, geriatric psychiatrists. And so as we move forward, the wait lines are going to continue to get longer, and there's a real need for primary care to take the brunt or the initial diagnosis of Alzheimer's disease. Importantly, they're the ones that are going to be dealing most with older adults who have multiple chronic conditions, because these individuals are less likely to be referred. So with the next part of my talk, I'm going to separate it into 2 parts. One, talking about the effects and impact of comorbidities and medications on the interpretation of the blood markers, as well as a couple slides regarding race and ethnicity. And then I'm going to end with some slides to put out in terms of considerations as we try to implement these blood markers at the population level, from gaps and challenges to also ethical considerations. So in terms of thinking about interpreting this in primary care, this actually started or came to our attention about 3 or 4 years ago. And in the Mayo Clinic study of aging, we have a generally population community-based cohort in Olmsted County, Minnesota. And so I wanted to take a look, just, how do these blood biomarkers look? Are there any factors that might affect their interpretation? And so here I'm showing you plasma p-tau 181 and 217. The bars are unadjusted, and the red lines are age and sex adjusted. And to just give you kind of a standard to start with, on the bottom, this is the difference, mean difference between individuals who are amyloid PET positive and amyloid PET negative for both 181 and 217. Now, what we have surprisingly found was that the individuals who had CKD, CKD really affects the blood markers, such that the difference between somebody who had chronic kidney disease stage 3 or greater versus who did not was basically the same as the difference in plasma p-tau levels between somebody who was amyloid PET positive versus negative. We also found elevated levels of p-tau among individuals with a history of stroke and history of myocardial infarction. We also looked at other markers in the population. So this is looking at plasma amyloid beta 42 and 40 as well as the 42 to 40 ratio. And again here, when we're looking at 42 and 40 alone, we see that chronic kidney disease is associated with higher levels of these biomarkers. Notably, when we look at the ratio, it's not as, some of that is attenuated, and so it was really only significant in our cognitively unimpaired group. But again, we also, with some of these cardiometabolic factors, found that those appear to affect some of the levels as well. Now, there's been a lot more research examining chronic kidney disease, kidney function on these blood markers, and it's quite notable that most of the work has been focused on stages of chronic kidney disease, or typically it's CKD or no, yes, no. But there are some studies that have looked across the range of kidney function. And it's quite noticeable that even within what would be considered the normal range of kidney function, you still see really linear associations with changes, associations with NFL and GFAP strongly correlated with EGFR. So, as we think about this, there have been several studies that have come out now, community-based studies, epidemiological studies, that adjust for chronic kidney disease, and they say it doesn't really, it doesn't make an effect on the outcome. And the reason why I don't think it makes an effect is because Anne Murray, who is the PI of the brain and kidney disease, has not found elevated amyloid PET in those individuals with chronic kidney disease. So the association with cognition has been more cerebrovascular. So as a result, if you adjust for chronic kidney disease, it's not a confounder in the epidemiological sense, and really doesn't necessarily do anything. On the other hand, we also need to consider those studies that are adjusting for some of these factors, are looking at this on the group level. And so how does it affect an individual patient that's coming in that's going to get a diagnosis? And so this is a figure of some work that I had conducted with Melissa Murray, where we were trying to look at the correlation between the plasma biomarkers and pathology. And interestingly, we had this one person at the very end who had the highest levels of p-tau217, but had moderate amyloid pathology and really no tau pathology, or very, very low. So this person would not have been diagnosed with Alzheimer's disease. And so we were trying to figure out, I went through the medical records, is there any reason, or can we try and figure out why this person would have been falsely diagnosed? And what we found was that within 2 weeks of the study blood draw to measure our blood markers, this person had a creatinine level of 3.7. So on an individual level, this person coming in without having to consider their chronic kidney disease would have been diagnosed with Alzheimer's disease, when in fact they actually don't have Alzheimer's pathology in their brain, or very low levels. Now, there has been some work I had shown you with amyloid beta. When we use the 42 to 40 ratio, there appears to be less of an effect of chronic kidney disease on the ratio. And some additional work now has suggested that if we look at a p-tau ratio, so for example, a phosphorylated to non-phosphorylated ratio down here, that seems to mitigate some of the effects of chronic kidney disease as well, as compared to looking at p-tau level. Now, this particular study had, it was generally about CKD3, and so it's more mild chronic kidney disease. So we do have a study. Tommy is working on this with Carrie Sheets and Anne Murray at the University of Minnesota to start looking at the p-tau versus BD-tau ratio to see if that may mitigate in more severe stages of chronic kidney disease. Now, I've already shown you this figure, but what I didn't show you last time was that in addition to the effects of CKD and some of the vascular factors, there's also an inverse association between body mass index and plasma p-tau levels. And this has also been reported in several other studies, such as in the BioFinder 1 and 2. Now, the potential reason for this was discovered a few years ago looking at MS patients and controls. So they were looking at NFL as a potential biomarker, and they found that plasma NFL decreased with increasing BMI. And then in further research, they found that the reason that occurred was because with increasing BMI, there's decreases in, or increases in the blood volume, which therefore causes it appear that there's a smaller concentration of NFL in the blood. And this is, certainly a peripheral factor, because when you look at the correlation between CSF NFL and body mass index, there is no association. Now, what might this mean? It's hard to think about how to incorporate this clinically in terms of adjusting or factoring in BMI, but it's more apparent. I think this gives an idea of what the potential impact could be. So this was a study of obese individuals that were undergoing gastric bypass surgery. And at baseline, compared to lean individuals, they had significantly lower levels of NFL. Roughly 6 months later, after gastric bypass surgery, when they went from a mean BMI of 41 down to 29, they had higher levels of NFL, and then it was no longer different from lean individuals. Now, cardiac conditions are also of concern in terms of the interpretation of these biomarkers, particularly blood amyloid. Amyloid beta accumulates in the heart of Alzheimer's patients and induces AD-related cardiac amyloidosis. And higher levels of plasma amyloid beta 40 and 42 have been associated with an increased risk of heart failure as well as with myocardial infarction. So recently there was a study that came out in JAMA Neurology showing that sacubitril or Entresto can alter plasma markers. So more specifically, they found increasing, for those on the medication, they found increasing levels of amyloid beta 42 and amyloid beta 40, but they found significantly decreased levels of the amyloid beta 40 to 42 ratio. So again, decreasing levels of the A beta 42 to 40 ratio in the plasma is indicative of Alzheimer's disease. So this person could potentially be diagnosed with Alzheimer's disease when in fact they may not have Alzheimer's pathology. And this is a concern because we are hearing that more cardiologists are starting to use these blood biomarkers, because certainly cognitive impairment is quite common among the cardiology population. Notably in this study, they did not find a change in plasma p-tau217, so that may be a better marker in this population. So to summarize these few slides, we've shown that chronic kidney disease can really increase the level of these biomarkers in the blood. Now, there is a lot of work, and you'll probably see a lot of papers looking at comorbidities beyond chronic kidney disease and BMI. But as we're thinking through these comorbidities, it's really important to separate those that have physiological factors versus those that are risk factors. Because if it's a risk factor as a comorbidity, then that will likely be associated with some of these blood biomarker levels. On the other hand, if you have something like chronic kidney disease and renal function that's affecting the level of the biomarker, that's more of a physiological aspect, similar to BMI, although BMI is kind of both, so how we factor that in, we're not quite sure. It is possible that the use of the ratios may be more accurate, and so hopefully that's something that will continue to be pursued down the road. Increasing BMI is associated with lower levels of the biomarkers. Again, this is both a physiological consequences and a risk factor, so it's a little bit harder to think about how to interpret this for a specific patient coming in. But it may be something to think about as GLP inhibitors become more common. If they're used in older adults, it's important to know if somebody's lost a lot of weight recently, or if you're looking at these markers over time, you may want to look at change in BMI and take that as a factor. Pretty much all the work that has been done to date examining these chronic conditions have been examined in isolation. And so, for example, CKD and BMI can take the biomarkers in different directions, and so there's a real need to start understanding the context of the markers in the context of multiple chronic conditions. And then certainly further examination of how to incorporate the blood amyloid measures. And it might be that for individuals who have cardiac conditions, p-tau217 may be the best. Although, going back to some of our initial work, we did find that those individuals with a history of stroke and MI had higher levels of p-tau217. So I think more work still needs to be done there. So the next two slides in the theme of the conference, just touch on race ethnicity. So, certainly there are several studies that suggest, based on CSF and imaging, that Black Americans have lower levels of Alzheimer's disease pathology compared to white Americans. And there's also some studies that also suggest differences in blood levels. But there's also a lot of other studies that have not found differences. And so I think we really need to move forward and look at these different characteristics of the studies and try to understand why we're seeing these differences. And one potential reason could be differences in comorbidities. So we know the comorbidities that I just talked about are much more prevalent in African Americans compared to whites, as well as in Hispanic Americans. And so it's really important as we're thinking about these racial ethnic differences, not just solely based on racial ethnic, black, white, Hispanic, white, whatnot, but really to take into account all these other factors. So what is the prevalence of comorbidities? How does it compare? What are other social determinants of health that could also have an impact on the markers? And to highlight as well that although, one of the big disparities, I think, is that there are limitations of studies that have CSF or amyloid PET, which are considered the gold standards to compare the biomarkers to. Numbers of individuals enrolled who are African Americans, Latinos, and other races or ethnicities are really quite low. And typically their characteristics are not generalized to the population. They tend to be healthier and also much more highly educated. So there has been discussions in terms of the blood markers with incorporating algorithms, such as ApoE4 genotype. And I think we have to be extremely careful about this. So we know that the ApoE4 allele, although similar in frequency, is less penetrant for individuals who have greater African ancestry, also less penetrant for individuals who have greater American Indian ancestry. And so if we start incorporating broad use of these algorithms, that could really bias our interpretation and diagnosis of Alzheimer's disease. So at this point, I think it's important to keep them separate. There's also been a lot of discussion about if there are differences in levels between race ethnicities, whether we should have different cut points. So whether for PET, for CSF, or also for the blood-based biomarkers. And I think, I just mentioned ApoE4 is not as penetrant for those with greater African ancestry, so it may make sense that there may not be as much Alzheimer's pathology, and there could be much more or other chronic conditions that are contributing to the dementia. So I think, we need to take history into account. For example, with EGFR, which initially used race and ethnic-based cut points, and now are no longer being used because of the problems with that. So maybe there will be a role down the road, but for now, I think we need to be very cautious before we think of incorporating those. So in this last section, I'm going to talk a little bit more about thinking about how to implement these biomarkers at the population level and really the gaps and challenges. And we do have at Wake two real-world primary care studies that we're just getting started and up and running. And that has really put, I've learned a lot in the process and where some of the barriers are that I hadn't even realized. So first, in terms of gaps and challenges, is the accuracy of tests in the real world and the consistency of the assay performance at the population level. And I think Tommy's going to go into this a lot more depth, so I'm going to skip over this. Other considerations are diagnostic considerations. So we know that Alzheimer's disease pathology begins decades prior to symptoms and increases with age. So there's a possibility that among the general population, a positive test could potentially be incidental. So it's there's a lot of discussion right now about potentially using the blood markers for asymptomatic individuals, preclinical screening. But at this point, we don't know what that means. Some of those individuals, if asymptomatic, could go on to develop dementia, Alzheimer's disease, and some may not. So right now, I think a strong suggestion, or I encourage, and I know it's a little split in the field, but these markers should only be used on individuals who have objective cognitive impairment. In addition to incidental findings, A positive blood biomarker test may indicate AD pathology, but as we talked about earlier, many of these patients have a lot of comorbidities. So that AD pathology could maybe be one part that's contributing to the cognitive impairment. And so we need to make sure that now that we have blood biomarkers of Alzheimer's disease, we don't make everything AD centric and take it in account with all other risk factors and potential contributions to the cognitive impairment. I also have a lot of concerns in terms of ethics. So given the ease of obtaining the blood-based biomarkers compared to CSF and PET, I think there needs to be a discussion and clinical guidelines as the cost-benefit ratio of incorporating the AD biomarkers, maybe particularly for those that have limited life expectancy, for those that may not be eligible for IV infusions or for some other factors. And I'm even more concerned about the impact of including the biomarker results in the medical record. So because of the Affordable Care Act, basically as soon as the blood draw is taken, it will be put in the patient portal. And so a physician will not have time prior to those results coming out to talk with the patients before they see the results. And there's certainly a huge need for education on primary care, but really also the patient perspective as to what the difference is between Alzheimer's disease pathology and Alzheimer's disease symptoms. So this means that there's going to have to be a discussion prior to the blood test where primary care sits down and talks about some of these factors, which of course we all know primary care is very limited and have limited time. In addition, there's, having we don't know what the potential ramifications are of having these blood markers in the medical record. They could potentially affect long-term care insurance, life insurance, disability insurance. And so again, that's a discussion that will have to be made between the PCP and the patient prior to undergoing the test. And then lastly, I think, in general, I think there's this idea that everybody wants to know whether they have Alzheimer's pathology or whether they have cognitive impairment, and I think it's more at the specialty level. But at the population level, that's not necessarily the case. There really aren't qualitative studies that have talked about or discerned what patients really want, what they want to know, and when they want to know it. And as we started to bring some people through our primary care pathway, kind of as testing our process, yes, we've had people that they don't want a cognitive test. They have a cognitive test, they're impaired, they don't want the blood biomarker. And so, it's important for us, and we're planning on setting up some qualitative studies to go in and try and understand. Is it the stigma? Is it, what are some of the other factors? And then how does that vary by SES and race and ethnicity? Okay, great, thanks. So in summary, we are really at an unprecedented time. This is such an exciting time to be in the field. We have some potential disease-modifying therapies. We have possible blood-based biomarkers. But we still have a lot to learn in terms of how to implement all of this. The blood biomarkers are certainly promising, but there's a lot of questions that remain. How do we interpret them? When should they be used? When are they potentially good enough if somebody can undergo a CSF or amyloid PET? And there's certainly a need to educate the general public as well as healthcare providers that will be at the front of this. And I do worry a little bit that poor implementation, or if there ends up being a lot of harm to the patient, for example, without disclosure that you may lose your long-term care, or you may not have access to long-term care insurance, or some other things, if that's not discussed ahead of time, it could potentially lose trust with the patients and providers. I do think we need guidelines and patient and healthcare providers' input on the best way to implement this, including what patients want. And then we also need to start looking from a policy angle to make sure that patients are protected and really consider some of these ethical aspects. Before I close, I do want to highlight we were recently funded to develop a national infrastructure to understand how to utilize biomarkers for the diagnosis of Alzheimer's disease in older adults who have multiple chronic conditions. And so this is really, we were funded late last fall. Our first funding year was 7 months, so we have to have an annual conference every year. We have to have pilot grants, so we're kind of, we should hopefully have a website coming. But I did want to say that our first conference will be April 29th and 30th in Winston-Salem. And so we'd love to have as many individuals there as possible. Our goal of the first conference is really to bring in people that are on the front lines and get their sense of what they're experiencing, what they need, what guidelines, what recommendations, what research do they need going forward. And then that will help our network try and figure out what to focus on for the next couple of years. So if anybody does have any questions, yeah, my email's on the next slide, but we'd love to have as many voices and input as we can.
You want to take one or two questions?
Sure, I'm happy.
Maybe one or two questions, please.
In some of your slides, you say that employee status is less penetrating for certain races or ethnic groups or something like that. Well, can you explain it, or at least because it sounds quite strange.
So what?
Genetically, there is no statistical difference between people with different skin color, or well, so
Yeah, so
genetically there is no difference.
So what the studies have shown is that the penetrance of the E4 allele, it depends on some ancestries. And
Can you define penetrance first?
I guess the effect of the E4 allele. So as an example, Chi Udemomo has a study right now. It's been looking at the Ibadan Indianapolis study, where they look at people from Nigeria who live in Nigeria and those that have moved to the United States and live in Indianapolis. And there have been admixture over time, and so they have less African ancestry. And they find that the frequency of the E4 allele remains the same, but it's not as much of a risk factor for those that live in Nigeria as in the US, because there's less African ancestry, or they have more admixed and less African ancestry.
So what you're saying, this is less risk for Nigerian descendants living in the US than in Nigeria?
No, there's more risk.
More risk?
More risk.
More risk.
And I'm happy to, I can send you some papers that really go into, I'm not a geneticist, but I can send you some papers that really nicely go in and explain the facts based on penetrance. Because they do see the same thing with more Indian ancestry.
I know what you're speaking about.
Right.
I know what you're speaking about, but basically this is quite hot question. Actually, this is effect of admixture.
Right.
But in my opinion, maybe this is not exactly APOE effect. It's probably interaction. It's probably quite more complex than that.
Yes, I'm sure it is.
So
Thank you.
Thank you.
Any other questions? One last question? No? Great. Bye-bye.
In one of your slides, you show that there is association between the biomarkers and different comorbidities. And could you one of them was chemotherapy.
Was what?
Chemotherapy.
Chemotherapy. Right.
And the association was negative. It means that it's positive for Alzheimer disease. Would you comment whether the biomarkers were measured before or after the chemotherapy, and how they are related?
Yeah, so in that particular study, it was people that had a history of undergoing, or a history of cancer and a history of chemotherapy. There really are not any studies in cancer patients looking at these blood biomarkers to date. So we have a grant in right now, we're supposed to hear March 22nd, where they will be funded, and so it's a breast cancer population. They were focusing on cardiotoxicity, so we'll have those measures as well. And we can look at the blood markers prior to the start of chemotherapy and then at periods over the next couple of years. Because right now, we don't know if it's cancer or chemotherapy or if they have any effect on the levels.
So one more question about the next slide after that, which is related to drug staging. And from this slide, it seems that there are at least two groups of people with different behavior, and the biomarker on drug staging. And considering that with increasing age, the drug staging is increased, and these two groups, it seems that they have approximately the same blood biomarkers. Could you tell us what this group could be, and whether they have different comorbidities?
Can you please point to the specific before?
And just kindly keep your questions short if you don't mind, I think.
Yeah. No, before this.
This is the
No. Is this the,
Yeah.
what you're talking about? So I guess I'm not sure what your question is. So we looked at plasma p-tau levels on the bottom, and then in relation to both all phase and rock phase.
Drug staging, the right figure. It seems that there are two groups at least. One with lower levels and the second with higher levels. And they converge to the same intermediate level of biomarker at higher drug stage.
So at 4.
Yeah, could you comment whether you tried to find what days and what additional comorbidities do they have?
No, I don't think, we didn't go into that much depth. I think through the medical record to extract all that information, we started out more with, this one person that's really clearly not of the pathology and what biomarker was not aligned.
Thank you. One last question.
No, it's rather a comment, because I'm highly genetic and I will probably forget. But what we saw is when we did a metabolomic study for plasma levels of antibiotics, we saw an imprint that looked like kidney disease, but in people who had kidney disease. And one of the most prominent markers was serum creatinine, which is used in most of the models to calculate eGFR, right? So it might be worthwhile for us to look into mediation analysis or something just to see if we can disentangle that signal a bit more.
That would be great.
Thank you so much.